Good morning, everyone. My name is Orsolya Gresits. I work at the Department of Orthopaedics, and I have 2 projects in this program. As a general background, I wanted to tell you a bit about cerebral palsy, which we are interested in. That's a condition which caused by a non-progressive lesion to the immature brain, causing various clinical appearances. As an orthopedic, we are interested in the pathomechanism of cerebral palsy on the musculoskeletal system. It's quite known. You see the scheme there, so how the primary brain lesion leads to the primary abnormalities like the increased muscle tone, muscle imbalance, and weakness, and through all those things, it will lead in the end to functional impairments, disability, and pain. Those are the potential treatment options in the hand of a pediatric orthopedic surgeon. So botulinum toxin injections, that's my first project about. Soft tissue surgeries and bony surgeries like the FDO I'm going to talk about in my second project. So yeah, my first project is titled No Evidence of Functional Benefit After Upper Limb Botulinum Toxin Treatment in Children with Cerebral Palsy. So once again, children with cerebral palsy, but now let's focus on the spastic upper limb. We have this treatment option, injecting those muscles with botulinum toxin. That's widely accepted and used in cerebral palsy that brings a temporal focal spasticity reducement. There's 2 questions about this treatment, if they are functional, so functional benefits, and if there's any other indication than reducing spasticity. So our clinical question was about, I cannot use the pointer, so function and indications. And that was our PICO. We did the systematic search, and after the selection ended up with 14 different RCT studies. To the results. That's my first forest plot. It's about decrease in spasticity. Spasticity is measured on a 4-point scale. Kids involved in this study had 2 or 3. And there's 2 halves of these forest plots. The upper half was measured during the toxin effect, the lower half after the effect has been vanished. And as you see, there was an almost 1-point overall decrease during the toxin effect, which vanished after it washed off. That's how this treatment works. Okay, our primary outcome of interest was different functional scales. As an example, I have here the so-called Melbourne assessment. A physical therapist do the assessment. Higher scores mean better upper limb function. The maximum score is 88. Kids had 3 and 2-point average change, which is neither statistically nor clinically relevant. Goal achievements are really important in cerebral palsy treatment, both at treatment planning and monitoring the treatment effects. So we summarized goal achievement results. This method, which is listed here, is called the goal attainment scaling. Similarly, higher scores indicate better results. As you see, both during and after the pharmacological effect, botulinum toxin treated kids did way better than the naive group. Okay, parents of these kids were asked to rate the treatment effects. We dichotomized that data to having an improvement and no improvement, and calculated odds ratios. They're like 2 weeks after the injection, 3 months after the injection, and 6 months after the injection. The pattern follows the pharmacological effect, and botulinum toxin treated kids did way better than the other group. So to summarize this project, we did a systematic search looking for RCT studies that compare botulinum toxin treated and not treated kids of cerebral palsy. We were able to add 14 different RCT studies with more than 600 patients. And in the middle, you see our main results. Botulinum toxin treated kids did better on muscle tone, goals, and the parents' opinion, and there wasn't any difference in terms of function. So that means that we have a highly positive subjective rating despite the no functional gain. And despite the quite many variables we analyze, as you see on the left side, muscle tone was the only thing which were changing. So we think that studying the effects of muscle tone, increased muscle tone spasticity would be highly recommended. Okay, we have some stringent limitations, and this project is under review at the Brazilian Journal of Physical Therapy. Let me move to my second project. Does femoral derotation osteotomy improve gait in cerebral palsy? So kids with cerebral palsy, but now focus on the lower limbs. Those kids develop gait pathologies over the time, like this one, which is called the in-2 gait. Now you see it, so thank you. Okay. The gold standard treatment for that in-2 gait is called the femoral derotation osteotomy. That's a surgical procedure. You see the schematic figure there, what we do. So it's the gold standard, we do it, we know it's working, but we wanted to clarify if this procedure has an impact, a positive impact on the gait function itself, so not just on the rotation. That was our clinical question, and similarly did the search, and the selection ended up with 44 papers of 26 different studies or databases here. Our primary results were gait scores. That's a standardized mean difference for S-plot. We used short term, meaning 1-2 years after the operation, and long term, which means more than 5 years after the operations. So I can say that yes, gait improved with this procedure. Okay, if I talk a bit about standardized gait kinematics, we have those graphs that we analyzed. I circled the ones we have results of, summarized. The rotational graphs improved significantly, and the others, like, we have somewhat improvement. Okay, just an example, I have quite huge forest plots in this project. That's the hip rotational, the change in hip rotation. We have also short-term, mid-term, and long-term results here. And we were concerned about the magnitude of expected changes here that I listed there. Okay, we summarized the success rate. So the rate of those kids who has the favorable outcome. So I would say that those surgeries which turned to be out like that the surgeon intended, and it's around 70%. And the relapse rate, so those are the kids who were corrected but relapsed over the time, and that's 14%. Okay, and so to summarize it, we did a study on this femoral derotation osteotomy, and we have kids who were operated and had a gait analysis before and after this operation. And as a result, I can say that their gait scores, hip rotation, foot progress angle, and step width improved. Success rate was around 70%, the recurrence rate about 14%. So I think that I can say that this FDO corrects in-toe gait sufficiently, and the long-term maintenance of positive results are sufficient. More studies need to be done on kinetics, which are the forces at the gait, and to analyze the cause of failure. Okay. And I'm doing the article writing with this project. And yeah, I have some additional activities. And thank you for your attention. There's a quote I put there because I think these kids are primary kids and not, patient from, that's a famous tweet from a pediatrician. It goes like, it's very important as a pediatrician to have a favorite dinosaur, bug, superhero, animal, and princess, because one never knows when it will come up in a conversation, and I put my answers there. So, thank you.
Thank you very much. This is really great advance and great presentation. I have to say that if something's personal, that I have a grandson who actually, I could just confirm this because he's a big, he loves dinosaurs. So we also have to keep up actually with this kind of thing. So this is very, very true. In your first study, if you can show your summary slide.
Yeah,
which contains everything. Yeah, I'm just curious. So there is a treatment with botulinum toxin, okay, and then there are measurements right after or during the and then there are other measurements later. Now, in the so-called function,
yep.
There is no difference, at least not in long term. And why in the other ones there is. So is this function, in quotes, is this really a good measure? Or what is the reason for discrepancy? This is question one. Question two, can this kind of treatment be repeated? If that works short term, that maybe actually in long term it could be kind of advanced, better?
Yeah, so thank you for your questions. Those studies lasted for about a year, and in most studies, kids were measured during the effect, so 1 month, 3 months after the injection, 6 months, and in some cases, 1 year after the measurement. So they measured the kids repeatedly, and yes, that can be, so the injections can be repeated. It's quite oftenly done so in the clinical practice, but we could not synthesize data from repeated injections because usually they lost the RCT study design because kids in the not treated group got treated as well. So yeah, and if that's a good option, it's upper limb. So the primary treatment goal is function. That's why we choose different functional scales.
I'm not criticizing, just trying to understand.
Yeah, that's why.
Questions from the students, maybe first. Here's a microphone.
Going for the why.
Thank you. Thank you for your presentation. My question is there a relevant effect on the age when the intervention happens? So, because I assume that children in lower age has higher ability to learn the movement, to increase the function. So is there any connection?
Yeah, kids in those studies had been between 4 and 10 years mostly, because in really young age you cannot really test the upper limb function because they are too young for those tests. And yeah, there could be. It's not really, it's been studied, there's not really much, so most probably there isn't any effect of the age on the results, but it's not really proven yet. So, yeah.
The question which is a little bit similar, that the severity of the cerebral palsy, the severity of the symptomatology, how much it influences in the different studies, the results, how is it homogeneous or not?
Definitely does. This treatment is used only on kids that has some upper limb function, so I would say the moderate ones, because if there's a rigid non-functional hand, you don't treat that because there's no point in that. A limitation which I have to note is that we could not differentiate between the unilateral and bilaterally affected people, and that's problematic because a unilateral one has a perfect and usually a seriously impaired upper limb, but the bilateral ones have usually 2 moderately impaired hand, and that is a difference.
Okay, thank you for the great talk. I'm not familiar with this topic. I'm a psychiatrist, so I don't really know what's the difference between the function and the goal-directed behavior when you measure the outcomes in this cerebral palsy.
Okay.
Yeah. So what is the goal?
So
achievement,
those
and what's
are
the
like
function?
functional tests. There's a physical therapist. There's standardized tests. Usually the kid plays. Like putting small objects in a tube and perform things like that, and got a score on that. In this case, there's goals like, I don't know, I want my kid to dress up on his own, and this goal gets pointed, like if it gets like +1 or +2 when a kid get perform that goal better after the treatment, and -1 or -2 if the kid deteriorates on that goal, and 0 if there's no change.
So maybe when they achieve the goal in any way, then it's a plus.
It's a plus, yeah.
And it doesn't depend how well or
you can rate it like +1 or +2
Yeah.
if it's better or way better.
Okay, thank you.
And so that's the row scores, and these T-scores are really complicated. There's a huge sheet for that, and you can weight the goals, so the parents can add like extra weight if that goal is really important for them or not. So that T-score is more than our mass as doctors are, but the row scores are like just -2 to +2 or 0.
Okay, thank you.
Hi.
Hi.
A few general comments before I ask my specific questions. First, and this is mostly for the students coming after you, please, if you show a PICO slide, let me read it, okay? Because this is new for me, and I need more than 3 seconds to understand what's going on. That's going to be, I'd rather have you slide out of time and let me read the PICO slide, okay? That's one thing. The other thing is, you mentioned in the beginning, and I'm a complete outsider, so please excuse my stupidity here, but you said that the effect of this toxin is well known?
The effect on spasticity.
On spasticity is well known. Okay, so that the added value here is that you're measuring other than spasticity.
Yeah.
Okay, that wasn't necessarily very clear for me at the beginning. Okay, I have a couple of specific questions. There was an Ashworth scale study where you used mean differences, right?
Yeah.
And the Ashworth scale is, as far as I know, is on 4.
Yeah, it goes from 0 to 4.
0 to 4. In these cases, are you sure that the mean difference is a good pooling output?
Yeah, there was a discussion about that with the statistician team, but
they suggested
they did it like that. So.
Because the thing is, this is really not really a continuous scale. That's usually the problem. It's like, the grades. This is my pet peeve.
I know.
Story that
I know.
From 1 to 5, it's an ordinal scale, and we calculate the average of that.
So when we did this project, in most studies we had medians there and not means, and this discussion was going on for months if we are pooling means, but they said just means and standardized.
Okay, so this is not something I came up with.
Not my table.
Okay. And there was another slide, if you go forward a bit. Here, so these are, the one before, this one, yeah. So here you have Wallen 2007 twice.
Sorry, what do I have here?
Wallen 2007, the paper Wallen 2007 twice.
Because that study had 4 groups, and we compared, so one had just botulinum toxin plus regular physical therapy. One had regular physical therapy. One had botulinum toxin plus occupational therapy, the OT, and the 4th group had just occupational therapy.
And these were all separate patients, right?
And they were all separate patients, so that's a properly done RCT studies. So we decided to go like that.
And I'm not sure if the reviewers will spot this, but I will ask before the reviewers, maybe help you facilitate the answer.
Yeah.
How did you handle the fact that these are coming from the same paper? Was it handled somehow?
Some reviewers already asked it, but it's like if I show you my PICO, that we wanted to compare apelin botulinum toxin treated kids, and as a comparator, there was any kind of non-invasive physical therapies allowed. Mm-hmm. So I have comparisons, and each pair, like each intervention comparison pairs, differ slightly on if they had botulinum toxin or not. But yeah, there were different comparisons. As an orthopedic surgeon, I think that's quite okay.
One question that may come up, I'm not sure it will, it not necessarily, let's say 20% of the cases comes up. Depends on what reviewer you get. But the problem with this setup is that regardless that it's different patients within Wallen, was it Wallen?
Yeah,
Wallen 2007. Regardless of that fact that they are different patients, it's still coming, they are still sampling the same population Wallen 2007 had access to. That introduces a little bias that usually needs to be handled in the models. But this is often overlooked, so
yeah,
okay.
I know.
Okay. And the last question is concerning your second topic. There was a proportional forest plot?
Yeah, there was two proportional
forest plot.
Sorry, that one?
Here, this is the success rate of correction, right? So it goes from 42% to 85%. That's like a huge variability in success between papers. What's the reason of that? Do you know?
The main reason is that articles define success a bit differently. So some said, if I go back to, I'm trying to go back. So the graph we are talking about is hip rotation. So, sorry, that graph. I have a leash on me. And some defined it like B in the gray area, which means the line in the middle means the mean of normal healthy people plus
one
so
the
and
thresholds
minus one standardized difference. Some said like having at least 15 degrees improvement, so they defined a bit.
Okay, so the thresholds that they they define success with.
Something like that.
It seems very large. Okay. Thank you very much. Thank you.
More questions, please. Okay.
From the audience, anybody? Nobody wants wine. Okay, good.
They want wine, but don't worry about their own presentation. Don't worry about your presentation. Ask questions, please.
I'm not from the field, and I'll ask very simple questions, but maybe complicated questions afterwards. So the first question for all of you, and I'm sorry that you're the first one you couldn't prepare, would be, can we trust the data? And I'll ask then the questions regarding that. And then if you are doing meta-analysis, then you also identify gap in evidence. So what would be your next step? Is there any randomized trial planned or prospective observational study? So can we trust the data? I've checked here how they measured the outcome, and it's green across the studies. But were these studies, any of the studies, double-blind? And was the assessment team, after the intervention, blinded to the intervention and separate of the intervention team? Because if you're doing the intervention, then you assess the result, then that's not a good way to do it. So that's the first one.
Thank you. That's a really great question. You mean the Botox study, I guess. So I don't have the risk of bias results in any of my slides, but yes, they were properly done RCT studies. They were double-blinded, plus in one study not, but in the other 13 studies, all the assessors were blinded. But and I listed at the limitations that there are blinding programs in botulinum toxin studies, which means that if you inject, so there was a study where they injected, so they performed the sham procedure and injected the control group with saline, and still patients were able to tell in which group they were, because in the toxin group the muscle tone drops, the other not. So that is a problem in botulinum toxin studies in general, and yeah, that's what we know. It's there, it's present there, it's a bias.
And,
So patient definitely knew in which group they were. They tried to do the assessment like that the assessor did not know. So the ones who were assessing like the function things, they were blinded to patient allocation.
Another thing that is a bit following what the colleague has raised, is there an accepted minimal clinically important difference for the outcome measure you have included into your...
Yeah, in most cases there aren't any, or at least there aren't any that we know of, because this cerebral palsy is an umbrella term. Kids are really different. Treatment is always individualized. So no, there isn't any amount that we know that's the minimal clinically important change.
And the last one, and that goes also for all the others, did anybody aim for individual patient data meta-analysis? Because that is the true meta-analysis that matters.
Yeah, in 2 studies, I have individual patient data, and in my paper at least it's discussed at the discussion part.